Good evening and welcome to our Learn and Share conference call. I'm Russ Berry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is Ketogenic Metabolic Therapies for Epilepsy, and we're pleased to have as our speaker Dr. Anastasia Luniova, who's a pediatric epileptologist with Helen DeVos Children's Hospital. We're also happy that Lyndsay Cooper, a ketogenic dietitian at DeVos, is also able to join us tonight. Can each of you briefly introduce yourselves, talk a bit about your clinical and research interests, and describe your experience with this topic? Dr. Luniova, do you want to go first?
Sure. First, I want to say it is my great pleasure and honor to represent our hospital and our program in such a great organization as Epilepsy Foundation, and share our appreciation for your work that you do for our patients, and I hope this will continue for many years to come. As for ketogenic diet, that I got involved with more than several years ago now, during my training where I was working toward my degree in pediatric neurology and epilepsy, and that interest continued when I joined Helen DeVos Hospital in Grand Rapids more than 6 years ago now. And since then, Lyndsay joined our program, and we're very lucky to have her, and she will share more about her interests in a minute. And we are lucky to have a great group at Helen DeVos that supports many different conditions with use of ketogenic diet. We are still working toward expansion of our program, and there's a lot of work to be done. But we are very glad to have resources that we have today and hope to help many patients going forward.
Great. Thank you. Lyndsay?
Alrighty. Again, as Dr. Luniova had mentioned, I'm also very thankful to have the opportunity to have this discussion with you all. I joined the neurology team about approximately 4 years ago, so in terms of keto dietitians, I am relatively newer. I know there are some that are veterans, and I admire their work. My main interest and focus, obviously with the ketogenic diet therapies, are trying to adapt the diet therapies to as many different families as possible, regardless of their means or limitations. So that's kind of my main focus when I implement those diet therapies.
Great. Well, welcome both of you, and thank you again for joining us for this really important discussion. So while most people in the epilepsy community have heard the term ketogenic diet, the term ketogenic metabolic therapies has been increasingly used. Can you talk about this shift in terminology and how the metabolic impact of this set of therapies is central to their effectiveness?
Well, I probably should start with the premise that even ketogenic diet is a particular kind of case in this larger group of metabolic therapies has gained more widespread interest relatively recently in the clinical community. While it has been known for over a decade now, and the effect of fasting has been suspected for even longer than that. Ketogenic diet has gained its popularity very recently. And in the last decade, with increased use and better understanding of what it is and what the benefits it can bring, many specialists started looking in that direction, and with challenges that we keep facing and solving with every year that we work in our clinic, additional ways to improve overall function, not only neurological but biological function of human organism, increased use and implementation of this diet in many different areas. And the main focus of this therapy, of this treatment approach, is change in how our body consumes and produces energy for everyday life, for everyday function, and all of those variations, they fall under that umbrella of metabolic therapies. And as we keep talking more today, we'll expand on that a little bit.
Okay. And what do we know? Because I remember seeing at one point at one presentation on ketogenic therapies a PowerPoint slide that showed this highly complicated cascade of metabolic consequences that is induced by these diets. And what do we know at this point about like potential mechanisms of action? It used to be kind of thought that ketone bodies were the key thing, but now it seems like there may be multiple mechanisms of action. What do we know about what it is about the diet that actually makes it effective?
Great question. You're absolutely right, and I think I'm very well familiar with that slide that you're talking about, with lots of arrows and lots of boxes. And I think every year that slide gets updated, there are more arrows and more boxes added to it, and which makes it even more complicated. But I don't think it gets it any meaningfully closer to the ultimate why ketogenic diet works. To make things a little bit more simplistic, everything that our body does is tied to an energy supply and energy production, cleaning out the debris and waste, and replenishing of the nutrients and multitude of biological factors that contribute to the energy production and utilization machinery to its optimal capacity and optimal state. And in the traditional sense, glucose is the main source of energy. And in many experiments with animals and cells in a petri dish and studies in human beings with use of the diets and its modifications that lead to ketosis, the limit of caloric intake and limit of glucose consumption appears to be the major key factor that influences the switch, the overhaul in the metabolic state that happens in the organism that leads to the state of ketosis and the effects that we try to reach and use for treatment of multiple disorders.
Okay, great. So let's discuss the different types of ketogenic metabolic therapies. Can you review kind of the spectrum of therapies, highlighting the different nutrient ratios involved and the benefits and limitations of each variation?
Sure. So the ketogenic diet therapy, or ketogenic diet for short, is a group of dietary regimens that are very regulated in the way of how the amount of glucose or carbohydrates, fats, and proteins. And depending on the amount of each of those major nutrients as a part of the whole dietary intake, the list of major modifications could be divided into classic ketogenic diet, modified ketogenic diet, MCT-based ketogenic diet, low glycemic index diet or therapy, and modified Atkins diet. And in this array of modifications, the first that I mentioned, classic ketogenic diet, is the strictest and most regimented, the most regulated diet that has the least allowed amount of carbohydrates and proteins and the highest amount of fat to make what we call 4-to-1 ratio. What does the ratio mean? It means that 4 parts of fat equal 1 part of carbohydrate and protein taken together. Or if I was to reflect those numbers in percentage, then we have about 90% of fat that make up the calories for the entire day, and about 10% between protein and carbs. About 6% goes to protein, and about 4% goes to carbs. So that is the most classic, in a sense, of ketogenic diet, and probably the hardest one to maintain. And as ratio gets lower, 3-to-1, 2-to-1, 1-to-1, the amount of fat drops down to 70%, and protein and carbohydrate jumps up to 15% each, respectively. And the lowest restrictions that we have is modified Atkins diet, where carbohydrates are usually limited to the amount of grams instead of percent of calories. They could be limited to 20 to 30 grams a day, and fat makes up about 65% of calories consumed throughout the day.
Okay. And low glycemic index treatment, where does that kind of fall? And
So low glycemic index, yeah.
That?
So low glycemic index is a little bit different in the way that how foods and nutrients are calculated that make up the final ratio, but it is very similar to modified Atkins diet in the ratios with maybe a little bit higher content of carbohydrates allowed, with similar amount of proteins and just slightly lower fat that is required to maintain the diet. And there are instead of ratios, there are a list of foods that are known to not only contain a certain amount of carbohydrates in it, but also limit amount of insulin that those foods trigger, and by that decrease that effect that those metabolites make in digestion of food, that leads to low glucose content in blood, low insulin content in blood, and that leads to similar effect to what ketogenic diet does.
Okay. And MCT is medium chain triglycerides?
Medium chain, yes, triglyceride oil. So this diet is somewhere in the middle between classic and modified, probably closer to the modified diet. And the main difference is the quality of the oils or fats that are used. The modified, the medium chain fatty acids versus long chain fatty acids. It makes a difference in production of ketone bodies. And the MCT oil leads to higher ketone production, and a lot of times this oil becomes an additive, or an important additive to the ketogenic diet or modified ketogenic diet if ketone bodies are not produced in the amount that we anticipate, and that may contribute to the effectiveness of the diet in some cases.
Okay, great. And Lyndsay, just anytime you want to jump in with any comments, I'll just remind you, feel free to do that at any time before we move on to another question.
Okay, thank you.
Okay. So can you talk about kind of the hierarchy of situations where ketogenic metabolic therapy should be considered?
When we think of the dietary therapy or ketogenic diet, as we simplistically call it, typically it's a situation in my line of work, it will be a patient with epilepsy who has intractable seizures despite of treatment with multiple medications. Some conditions that do not come with seizures or intractable epilepsy still are considered and recommended for ketogenic diet, like GLUT1 deficiency. And when it comes to how we choose the diet, this is where a lot of factors have to be considered. And that may vary from how old the child is and what are the problems or challenges that that child is facing in their feeding domain, if there are any swallowing dysfunction, other personal preferences from family, other religious preferences or nutritional preferences the family already has in place that we have to consider. And of course, from a medical standpoint, there are specific syndromes and conditions that we know will respond very favorably to certain dietary therapies, and we usually turn to those first. At the same time, if there are metabolic conditions that we know that we absolutely cannot use certain metabolic interventions, then those things may influence whether we even can proceed with the diet, even if we want to do it. As far as choosing a diet for the person, it depends on the age a lot of times and personal preferences. Even before we think of effectiveness, because if we can't get patient or family to buy into an idea of doing the diet, then we will have very hard time reaching the point where we can say the diet works or diet doesn't work. So the first, we have to make it attractive to the family. And if it's a baby, it's probably one of the easiest ways to deal with it, because babies do what mom and dad says, and especially the younger ones who are bottle fed. But it becomes much more challenging for parents, and this is where the main problem will be. First, we have to make family and parents understand what we mean when we say ketogenic diet therapy, and what it means for their child, and how things could get better with implementation of that therapy. It is a very difficult decision for many parents to make from an emotional standpoint, because sweets and candies and pasta and pizza, they come with equivalent of comfort and happiness. And when we say, well, we shouldn't give them ice cream anymore, or the usual ice cream out of the store, off the store shelf, or candies can be used as treats, or anything that kids so used to having every day, and little gummies, that becomes very difficult for parents, and that will influence on how we structure the diet and how we build a plan for that particular family. From the medical standpoint, you mentioned ketones and ketone bodies, and by now we know that yes, ketone bodies are important, and if diet is not working well and ketone bodies are not produced in adequate amounts, we try to modify and reach goal. However, that's not the only one factor that influences the effect of the diet or the outcome. And factors like glucose consumption and blood glucose levels and insulin levels that sometimes need to be measured, that may affect how we structure the diet. I hope I didn't make it too complicated or confusing, so please feel free to ask me any questions.
Sure. So in terms of typically it's again people who have drug-resistant epilepsy and that would consider the ketogenic diet, and but there we hear from a lot of parents and adults with epilepsy who would like to consider the diet as possibly a way to reduce the number of medications they're on, or just are interested in trying the diet, even if they have well-controlled seizures. They just want to be able to be on fewer medications. Is that something you typically that can be considered as it's discussed carefully with the epileptologist?
The short answer is yes, absolutely, and we have these conversations all the time. And there are a number of patients that we did exactly that. Instead of continue using different medications, if we tried to and they didn't work, technically diet is becoming a valid option to consider. For those parents who have children with epilepsy who responded to one medicine, I had a number of parents who presented that question to me even before we started any medication or after we started one medicine, and we got a good response with good seizure control even without significant side effects. A lot of parents find idea of quote-unquote natural therapy or diet modification much more attractive than chemicals or pharmaceutical agents that we prescribe. With that attractiveness comes with a lot of strict routines and demand to maintain diet day in, day out. And there's very little room for days when you decide, I don't feel like doing it today. And if you miss a dose of medicine, you can catch up the next day. But with the diet, if you miss a day of the diet, it may go off the rails and things may not return to their pre-holiday level or state anymore. It is a little bit more challenging in that regard. And when I hear questions, can we switch from medicine to the diet? I usually explain what diet entails and what the expectations are for the diet. And for many, very quickly becomes clear that taking pills is not as bad as it seems to be on the first glance, but doing the diet may come with greater burden on the family, especially if there are younger children and more than one. And a lot of times it is entire family routine changes and entire dynamic changes and how things need to happen at home and how dinners are cooked or how breakfasts are cooked or school lunch packed. And not many families or many parents are still eager to switch to the diet from one effective medicine. That being said, I don't want this sound like the diet is something scary and difficult. While there are challenges, this is a great option for many patients, especially if medications don't work. And with these challenges in place, this is not to say don't consider the diet. When you hear me say that it's difficult, it means more work needs to be done up front. More education needs to be done before diet is started or even planned. So when we get to the point in day when the diet is started, we are ready for those challenges and we have greater chance to succeed and bring all the benefits that we can to the family with little restrictions as possible.
Great, great. So now I'd like to talk about outcomes. Can you discuss what the research has shown regarding effectiveness of the different diets? And any kind of notable finding in any specific subgroups of people with epilepsy?
Interestingly, there are, I probably should start that research in ketogenic diet world is increasing every year, but it is still not at the level where medical community is considering high degree or high fidelity research for the reasons that, one, it is a relatively recent addition to the array of treatments that we use in clinical practice, but also the multitude of variations of how medical centers operate and policies they apply inside the institutions and number of patients that they take care of, and lack of wide network that connects all those centers into one where a number of patients could be accumulated into larger study limits us to get data to that level where medical community usually uses research for. So with that in mind, all the studies that have been done that try to complete with as much evidence as possible, they found that comparing to medications, it is a very promising option for most of the patients. After a person with epilepsy fails two medications or seizures fail to be controlled with two medications, then addition of the next medicine comes with very low possibility that it will be effective in control of seizures. And that number in low single percentage, less than 5%, 3 or 4, depending what source you look at. And when we look at patients with intractable epilepsy who tried ketogenic diet, we see that in the first year, at least 60% of patients will have at least 50% or more reduction in seizures. So that dramatic difference in benefit definitely makes diet a very attractive treatment option for patients with intractable seizures. Interestingly, the effect of the diet was not correlating very well with the type of epilepsy or type of seizures or what medications they were treated with exception of very few syndromes of genetic epilepsies, of metabolic epilepsies, where we know treatment with ketogenic diet will be a first line that is recommended. Those patients actually may have more than 90% seizure reduction. In the past, if when we were looking at studies that were conducted in smaller groups over a period of time, it was found that seizure control may get a little less over time, and by the year 3 or 4, the number of patients benefiting from ketogenic diet drops down to 40% or even lower. However, similar studies were completed more recently. Again, unfortunately, small number of group of patients, but that number did not seem to drop as much. In fact, it stayed very similar. If there was a decline over the years, it was not as dramatic and not as significant. And I attribute that difference to new things that we learn about the diet, new techniques and strategies that we implement by learning and experiencing more and more patients, making the diet more effective, more tolerable, and obviously we're learning also how to choose patients better and for the right reason. With the right education and support, it is a very valuable and very attractive treatment options for many patients.
Great. Just roughly, either from research studies or from your kind of your clinical practice, how common is it for people to become seizure free on the diet? Is that in the higher or lower than 25%?
Seizure free, so that number is not as high. Usually it is less than 25% when we speak of 100% seizure freedom. When we speak of seizure reduction, more than about 60%, rough numbers, 60, it varies from 55 to 68%, depending on the group and centers. Will have more than 50% reduction, and some patients will fall in more than 100% seizure reduction, but less than over 50% reduction. It's about 75% seizure reduction. It falls in about 30% range. I think I'm wrong with my math. Hold on. 60 to 25, another 20% or so will have for about 75% seizure reduction.
Okay. And then, is in general are the less strict versions of the diet, like the modified Atkins and low glycemic, are those just overall slightly less effective than the original ketogenic diet, or are rates fairly, or effectiveness fairly similar?
Interesting question. The short answer is probably similar, but at the same time, the data isn't as robust, even with all the limitations that we have for classic ketogenic diet. A low glycemic index and modified Atkins diet have been used and are being used more in adults than in younger children. For reasons that we all very well familiar with. We just don't like eating what we don't like, and we want what we want, and putting as little restriction as possible on the dietary regimen makes it a little bit more attractive to patients and make them a little bit more motivated, increasing the possibility of adherence to the diet. And when those two were compared, in some studies, a low glycemic index was a little bit closer to modified Atkins and comparable to ketogenic diet, but ketogenic diet was still a little bit better. If you take into account of side effects of the diet and how people did not tolerate the restrictions, then overall balance was tipped toward low glycemic index and modified Atkins diet for its overall usability, but for effectiveness, ketogenic diet was a little bit on top of that.
Okay. And just overall discontinuation rates, is there data on what percentage of people discontinue the various diets?
Most of the people will discontinue the diet. I would say over 80% of the people who start a diet will discontinue it. Some patients will stay for several years. Some patients will stay for a few years. Patients like GLUT1 deficiency or some other metabolic conditions, they will stay on the diet of some sort, either ketogenic or modified Atkins, pretty much for as long as they want, and we always recommend to maintain some degree of carb limitation in those patients because we know how negatively it will affect them if they break the diet. From the seizure standpoint, we're looking at, as with any medication, it is a treatment, and we're looking at least 2 years of therapy to begin with. And following those 2 years, again, like with any medications, it depends on the benefit the patient gets, and based on their relationship with the diet by that point, we can go for longer or we can discontinue. But as a main treatment plan, it's 2 years of treatment to begin with.
Okay. And then in terms of, I guess, early discontinuation, like someone discontinuing it because they can't tolerate it or because of side effects, and they don't really get a chance to see if it's even effective because they simply can't stick to it. Is that roughly like what percentage would fall into that category?
I don't think I will pull an exact number, but it does not cross a 25% threshold, and I would say less than 15.
Okay.
And I think even that will be a little elaborate. And most of the time, it's either teenagers who don't like restrictions or parents who become quickly overwhelmed, and that is another opportunity I want to take to underscore how important it is to get through education and preparation and discussion of the diet to minimize those negative outcomes that lead to discontinuation of the diet outside of its effectiveness or complications.
Okay, great.
Sorry, this is Lyndsay.
Yeah, go ahead.
Yeah, I just wanted to add on to that. I think we do a pretty good job of educating families when they come to us to initially be educated, to really say, if you're going to do this, we really want at least a 3-month commitment, because that's really the time frame that we will hopefully see those seizure reductions and those benefits. So I feel like a good majority of our patients at least stick with it for that time period to see if we can improve their seizure activity.
That's really good to know. Yeah, thanks. So what has the research shown in terms of any additional benefits of these therapies for people with epilepsy beyond just seizure control, like any potential improvements in mood or cognitive function or anything along those lines?
Very interesting question. This is I would say, hot area at this point because a lot of different centers are looking at use of the diet, and this is one of the terms. If you try to look into metabolic therapies, one line that will keep popping up is cancer therapy, and this is something that has been growing in the last decade, very carefully and slowly in many corners of our country and in the world. It's not a mainstream approach by any stretch of imagination, but more and more data is being collected in benefit of treatment of inoperable or high-grade gliomas like glioblastoma, brain tumors, breast cancers, in the period of chemotherapy and radiation therapy, and not as instead of radiation or chemotherapy, but in addition to maximize effectiveness of the chemotherapy and radiation and minimize the negative effect of those, and ultimately aiming at improvement in quality of life, increase in survival, and decrease in complications from therapy, from cancer therapy. The other areas that are being that are growing in use of metabolic therapies is ALS, Alzheimer's, multiple sclerosis, traumatic brain injuries and recoveries and rehab after traumatic brain injuries, pain and inflammation, like fibromyalgia, depressions. A lot of these problems are they have a lot of connections with some degree of inflammations at a neuronal level, neurotransmitters, energy consumption, energy storage, energy metabolism. And with ketogenic diet being such a strong tool that taps into that pathways directly and modifies and changes gene expression and regulation on such fundamental level that it affects entire organism and brain in particular in the ways that no medicine can. This effect, and again, this is multifold benefit that we see with the diet. It cannot be replicated with just taking a pill. And more we learn about it, the more and more areas we consider for use of this diet as a therapy. Autism is another area that is increasingly involved with ketogenic diet therapies. Behavioral problems, tuberous sclerosis complex, and a lot of many other syndromes that could potentially benefit from this therapy.
Great. And then in terms of patients with epilepsy, have you anecdotally or noticed any improvements in things beyond seizure control, like reduced anxiety, reduced depression, improved cognitive function, anything along those lines?
Anecdotally, I can tell you it's there. We are starting a little project specifically targeting changes that you mentioned, the cognitive function, attention, mood, behavior, in patients with who were treated with ketogenic diet. And based on that little pilot that we're starting, we will plan for prospective study in our patients, specifically targeting those aspects of their daily functions. We know that patients with autism, they will, some of them, obviously not all of them, but some of them will respond with significant improvement in their core symptoms where their socialization, interactions, and behavioral regulation becomes significantly better. Those patients who on the diet may may have improvement in their focusing during the day. They're more present, they're more grounded, they're more involved and engaged, they're more awake. Their sleep may become better regulated, and I had a number of patients who had good seizure control, and after 2 years of successful treatment, they were not very interested in going off the diet specifically for those reasons. They really liked the effect of the diet on top of their seizure control. So the short answer is yes, there's more than just seizure control. There's much more to the diet than what we see, and what we see is only the tip of the iceberg.
Great. And I'll be eager to see more results from that study you're doing. It's exciting. So I think a lot of people assume that, as we kind of mentioned before, that because these therapies involve food and are natural, that they have no side effects, but significantly changing the body's metabolism can sometimes create unwanted effects. And this is one of the reasons why it's recommended that these therapies be supervised by a neurologist and a dietitian. Can you discuss some of the potential adverse effects of ketogenic metabolic therapies and some of the testing that might be recommended to monitor for these effects?
Absolutely. Just like with any treatment, ketogenic diet is not the one that comes with absolutely no risk of side effects or adverse events. And those are could be divided into more common and less common. And one of the most common ones that we deal with is constipation, and Lyndsay can attest to that. And I know she hears a lot from patients when we deal with that. The other possible is kidney stones. Sometimes abdominal pain, sometimes nausea. Less commonly we see change in calcium metabolism and increase in cholesterol to the extreme levels or very high levels. Very rarely patients may experience change in liver enzymes or pancreatitis. Obviously, osteoporosis and bone health is one of the risks for patients who would stay on the diet for a very long time. Or for patients in our population, we have a lot of those kids who do not walk independently, who don't bear weight. They are already at risk of osteoporosis, and even for a shorter period of time, it still may bring an additional risk for worsening of osteoporosis and even occult fractures in their, especially in their long bones. And monitoring would be very helpful and may trigger an adjustment to the diet. Every patient that we start, we screen for metabolic problems or metabolic differences that may prevent us from going classic ketogenic diet or ketogenic diet at all. But we also screen for vitamin D deficiency, selenium deficiency, zinc deficiency, and other microelements that may, if in short supply, may negatively affect everyday functions in metabolism. And every patient has ongoing or surveillance labs for kidney stones. We are monitoring electrolytes, we're monitoring liver enzymes, and when we see a problem, we try to modify the diet to address those and improve overall benefit while reducing the negative effect of the diet.
Great. And Lyndsay, anything you wanted to add?
I definitely agree with everything that Dr. Luniova said. I just want to add that sometimes we also might see a little bit of weight loss in the beginning of starting the diet therapy, or just plateau of weight gain, just because the classical ketogenic diets and more restrictive diets are calorie controlled. So kids don't always grow the same when they're on the diet therapy. Of course, our goal is not ever to have them lose weight, but the shift in metabolic function as well, from using glucose or carbohydrate as energy, which our bodies use so well to grow and gain weight with, to fat in ketone bodies, it does change the way that we use energy, and it is a little bit of a slower weight gain. So I try to educate parents that while we may see a slower growth in their children, it's definitely not ever intended to have them lose weight or stop growing altogether.
Right. Right. Okay, so what's a typical, if someone decides to initiate a ketogenic metabolic therapy, how do they decide which one to start with? We kind of talked a little bit about that already, but are you more likely to start on a strict diet and then loosen up if necessary, or kind of start with a less restrictive diet and ratchet it up if it's not effective? I'm thinking what we said when we discussed earlier, it's probably the latter. But and then once you decided to start and you've selected a diet, what type of counseling is received, and then how is that therapy initiated?
So before we even consider what kind of diet would be most beneficial for the patient, we sit down with the families and we go over what the diet is, what this concept entails, and what does it mean to be on ketogenic diet. Sometimes we have parents who have done that or some sort of ketogenic diet for different reasons themselves, and they are a little bit more familiar with the concept. For some, it's a very unusual situation where a lot of carbohydrates are excluded, and kids are not eating a lot of bread or pasta or pizza, and it may be a great concern to them. But once we have gone through initial review of what we do and what it means, a lot of times parents will say, well, if there was an option, then I would prefer ABC. And for many, I personally, from a medical standpoint, before kind of final decision is made and final plan is made, I favor low ratio classic ketogenic diet or classic ketogenic diet, maybe up to 3-to-1 if possible. But when it comes to treatment, obviously if I have a teenager who says, absolutely not, I will not even discuss this possibility, I will encourage them to think about low glycemic index diet or modified Atkins diet. And when it comes to parents, they're definitely much happier with starting with modified Atkins diet than classic ketogenic diet for obvious reasons. And when we start the diet, there's a series of tests and lab tests that we do to screen for situations where diet should not be considered. We kind of get a baseline electrolytes and microelement state. Lyndsay will take that into account for her recommendations on vitamins and supplements when we start the diet. And if it is modified Atkins diet, it's something that can be done with Lyndsay's very helpful guidance at home gradually. It takes a little longer. But it doesn't require admission to the hospital. When kids are young and classic ketogenic diet appears to be the better choice, then we prefer to do that in the hospital, which will take an admission for at least a few days, up to 3 days to begin with, when we advance the diet every day, and we monitor labs and glucose levels and emergence of ketone bodies and in blood and urine. They get a lot of education during that admission, and by the time they're ready to go home, we know that they are at their target ratio, that they tolerate it well. There's no issues with glucose maintenance, and parents are educated on what is a sick day, what to do if kid feels nauseous, what to do if there's a fever, what to do or who to turn to if kids don't want to eat, and things like that. And when they are on the diet, we see them regularly in the clinic, at least every 3 months for the first year, and a little bit more relaxed down the line, depending on the situation. They have surveillance labs on several occasions, depending on, again, how well they do or if they're having any issues. We are doing annual bone density scans for those who are at higher risk for osteoporosis or exacerbation of that. And anything that comes in between, Lyndsay and I are both available to those families who need support and guidance in between the visits. And Lyndsay meets with families, and this is where she will probably speak more to that. She has resources that she shares with parents that support them from day to day in the operational standpoint.
Great, great. And during the pandemic, has telemedicine helped to kind of streamline some of those visits? And do you anticipate telemedicine becoming a more widely used tool in implementing ketogenic therapies in the future?
Telemedicine was kind of slowly creeping up into our domain, but with pandemic, things escalated rather quickly, and now we are all on board with virtual visits, and half of my patients have had at least one virtual visit with us. When it comes to patients on the diet, it is always helpful to meet with parents and family and patient in face-to-face for exam, for discussions. But we have started the diet with patient first meetings being virtual, and it worked out well. So it's definitely not a negative factor or detriment. If the diet is necessary, we can make things work depending on the individual circumstances, as long as we have an open line of communication and work together.
Okay. I'm going to jump ahead here a little bit, just given the time. So let's dive into the day-to-day aspects of the various diets. Can you walk us through an example of a typical day on the traditional ketogenic diet?
Sure. This is Lyndsay. So depending on the family, a morning may start by preparing a meal for their child as needed, or the family may have prepped meals in the freezer that they'll use already prepared. Most families have scheduled meal and snack time, which make it easier to carry out the diet therapy. It's easier to prepare meals or ingredients for meals ahead of time, sometimes 1 to 2 weeks in advance, but not all families have that capability or time to do so. But for families that prep foods ahead, they often tell me that they designate one full day on the weekend or maybe a day off during the week to dedicate solely to that, where they'll prepare up to 1 to 2 weeks of meals for their child at that time. For families that make meals on the go, the prep time is likely a little bit longer depending on how many ingredients the meal has, maybe an additional 2 to 5 minutes to weigh each food or liquid that they're using, then maybe an additional 5 to 10 minutes to cook or prepare, as in most cases the foods are different than what the rest of the family is offered, or maybe some of the foods are the same, but they have additional ones. The food gram scale will almost always be out, in addition to other plates, cups, utensils, spatulas, or other bakeware that family may use. The other good thing about the diet therapy is that it can be personalized to fit a particular family's needs. So it can be as simple or as complex as that family prefers, or however it works for them. The child may only have the allotted number of meals and snacks per day, as it is calorie controlled. So they kind of know going in to a day, okay, I need to prepare this many meals and this many snacks for my child. And that number and calorie levels determined by a registered dietitian, usually based on child's energy needs and growth. So an example, simple ketogenic, like classical ketogenic diet therapy menu may be for breakfast, they'll have scrambled eggs with a small amount of cheddar cheese, turkey sausage, a larger portion of butter, depending on the ratio, and then maybe a vegetable, like butternut squash, for example. Lunch might be a hot dog with some, like a mayonnaise-based dip, So sometimes my families will mix ketchup and mayo together to get part of their fat content, and then they might have a fruit or a vegetable on the side. I do try to encourage that for the carbohydrate portion that they're allowed to have, that we try to integrate as many fruits and vegetables as possible, just because they are so limited on the diet therapies. And with, things like constipation as a side effect, we definitely want to make sure that we get as much fiber in as we can as well. And then dinner could be, like, for instance, a ketogenic spaghetti might be use of pelmeni noodles, which are a fiber-based noodle, very low carbohydrate. They might use Walden Farms brand tomato basil sauce, which is a low carbohydrate spaghetti sauce, added with some heavy cream, ground beef, olive oil, Parmesan cheese, and a vegetable. And then snack could be as simple as vegetables and ranch dip. Of course, depending on the child's ratio, it varies quite a bit, depending on what they can have. But that would be kind of like a simple menu there.
Great. And is there any kind of daily testing that needs to be done, like self-administered tests or anything, blood tests or anything like that?
Yeah, good question. So we typically have our patients test urine ketones at home, depending on their diagnosis. But for most patients, it's urine ketones. And in the first 3 months of the diet therapy, it's usually twice a day, once in the morning and once at nighttime. For some of our GLUT1 deficiency patients, we do blood ketone testing at home, but that is on the rarer side, so it's usually not blood testing.
Okay. And so contrast the traditional ketogenic diet with a typical day on the low glycemic index treatment or a modified Atkins diet. How would that differ?
So these diet therapies, as Dr. Luniova mentioned, are more liberal than the classical ketogenic diet therapy. So for a patient on modified Atkins, the only measuring that's required is counting net carbohydrate. This diet is not calorie controlled, only carbohydrate controlled. So a net carbohydrate is the total carbohydrate minus the dietary fiber of a food, just to kind of give you a little background on that. They will be given a daily net carbohydrate limit to follow by a registered dietitian based on the age, tolerance, and response to the diet therapy. An example could be a limit of 15 to 20 grams net carbohydrates per day. So to kind of put that into perspective, that one serving of regular Cheerios has about 25 grams of net carbohydrate, or it's about 1.5 cups. So in this particular patient's situation, that would be more than the entire day's worth of carbohydrates that they would be allowed. The other thing we encourage on this diet is fat. We know that fat is the main macronutrient that fuels the body during these diet therapies. So we don't necessarily give fat gram goals per se, but if they're not consuming enough fat, we will see potentially weight loss, lower levels of ketosis, different things like that. So it is something that we encourage and give examples and try to fit it in every meal and snack. So kind of an example, the foods that modified Atkins patients might eat are pretty similar to classical ketogenic diet. It's just that they're not as restricted. So, for example, where classical ketogenic diet, everything has to be weighed on a gram scale to the exact ratio that child is prescribed. For modified Atkins, the proteins are not restricted. The fats, there's no specific limit, just the carbohydrates. So, for breakfast, it could be the same things. It could be scrambled eggs made with butter, turkey sausage patties with a side of cream cheese. They could have almond milk as well as their carbohydrate amount allowed. Lunch could be turkey lunch meat with cheddar cheese, side of mayo and mustard, celery with side of ranch. Dinner might look like grilled chicken breast with a side of ranch, or half a cup of cooked broccoli with butter, something along those lines. And then the Low glycemic index therapy is even more liberal of a diet therapy, only restricting net carbohydrate intake to around 50 to 60 grams per day for all patients. And they only choose carbohydrates that are considered to have a low glycemic index. As Dr. Luniova mentioned earlier, it's basically the body's response to when they consume that type of carbohydrate. It's a lower insulin response or lower blood sugar spike as well. So there's a complete list available, but typically we provide that. And some of those foods or carbohydrates might be things like apples, blackberries, oatmeal, chickpeas, celery. So there's a wider variety of foods they can have on that diet therapy. And with this diet therapy, the low glycemic index, ketosis is generally not our goal with the diet, this particular diet. So it is, like I said, the most liberal of the choices.
Right. You mentioned people, parents often preparing for the classic ketogenic diet, preparing food on one day of the week for a week or two at a time. Do you find the same sort of thing with modified Atkins and low glycemic index, or are people more able to kind of do that on a daily basis, kind of prep as you go?
Yep, I would definitely say that modified Atkins, low glycemic index, I see more often they're just kind of preparing as they go, just because it doesn't have to be weighed out on a gram scale. The only thing that really has to be measured is, the carbohydrate source, which is usually just by a household measuring cup or measuring spoon. So I don't see them prep as much.
Okay. So what are some of the staples of these diets that you'd want to have in your fridge and your pantry?
Oh, that's a great question. So some of the main things, typically when I meet with families and try to work on how we're going to start the diet therapies, we go through the list of things that they have already when they use in their home, and we'll go through different proteins, different fats, and different carbohydrates that are acceptable on the diet therapy. So some of those staples may differ between families, but I try to always make sure that, they have their staple fats. So that may be things like butter, various types of oils, like olive oil, avocado, MCT, vegetable oil, canola, whatever that family uses, or even things like mayonnaise, avocado, heavy cream. And then, we go to the different types of protein, which could be things like eggs, shredded cheese, various types of nuts, the macadamia nuts, almonds, chicken breast, hot dogs, any type of beef or turkey, ham. If the family's vegetarian, then it is a little bit more of a challenge to meet those protein needs sometimes. But other things like low carbohydrate vegetables, what the child likes, what the family has, like broccoli or Brussels sprouts, or lower carbohydrate fruits, strawberries, blueberries, raspberries. And those are kind of just the basic things to prepare a simple meal. So, as long as they have their child's preferred foods, fat, protein, carbohydrate, they'll be able to prepare a quick meal anytime for their child. It can be very complex, depending on the family's preferences, making things like muffins, keto muffins, and keto pancakes, and different things like that, which require other staples. But I would say for a majority part, I try to make sure that the families have at least some of those, simple staples at home.
Do you find that families, a significant percentage of families use kind of off-the-shelf ketogenic specific products? Like there's, shakes and drinks and various bread substitutes and things like that are designed for ketogenic diet. Do you find a fair amount of use of those, or are those used less often?
I have a few patients that like to use those. The main issue I see with some of those products are that they may advertise as ketogenic, but they're not truly ketogenic in the way that we need it to be. So they may use a large amount of artificial sweeteners or things that we have to, that, count towards this. They may not get a good amount of that product. And, I really think most of my patients, if they use the keto bread, they may only get a quarter piece of that bread for a meal. And that sometimes is not enough for them to sacrifice, a vegetable or something like that.
Right. Okay. So social factors can also make these diets challenging. Food is such an important part of our culture, and unfortunately some people are not particularly understanding when they encounter people who eat differently. So, and similarly, restaurants and schools and other public places often struggle to accommodate those on ketogenic diets. So what are some strategies you can recommend for navigating kind of a keto unfriendly environment?
Yeah, this is, fortunately I haven't had to deal with this a ton, but this can be one of the more challenging things, especially for our older kids. When the kids are younger, the parents oftentimes have a better ability to advocate for their child, but when the patient is older, I think they struggle a lot more with this because they don't necessarily know how to react or how to handle those situations. I think the best way is to support from the keto team for that family, especially a registered dietitian, to try to find new, well, I'm trying to think of the best way to say this here.
If you don't mind, may I jump in?
Yes, go ahead.
It is a very important aspect of the diet that you passed on. The older children, and especially teenagers, they are conscientious about their image, about themselves, about what they are perceived like in their own community and among peers. That addition of the restriction of what they eat and how they eat when they're out and about and at school and at social gatherings with friends, it is an emotional burden. And to improve the utilization of the diet in these patients, I feel that use of psychologists may minimize that problem to some extent. Working with the patient, working with the parent, as Lyndsay very well illuminated, that it's the advocating for your child is very, very important. But it takes a skill. It takes a certain mindset to realize that well-being and quality of life of the family, of the child, may be achieved and reached no matter what the kids eat. But it is very difficult to see it when you first hear about the limitations that the diet may impose. However, learning about it and reading about it and hearing about it and working on ways to disregard the limitations and focus on the benefits and the improvements in quality of life and reduction in seizures that may lead to increase in ability to attend those social events may allow parents and patients to realize that doing things a certain way is not a bad thing, and it doesn't reflect in a negative way on them in eyes of other people. And educating community, educating schools, teachers, and other parents, and holding maybe speaking events may bring this information and understanding of what is epilepsy and how important it is to have no seizures on an everyday basis or not have them at all. A lot of people don't understand the impact that disease makes on entire family, especially on the patient. And the diet is a way to for those kids to have a normal life. And I believe that when those kids, the friends, the neighbors, the classmates, other peers, when they understand the impact the improvement that this diet can make in those kids' lives, most of them will work with that person and they will help them. And I believe that may contribute to the success of the diet.
Right. Right. And I imagine in terms of kind of planning for going out in the community, that the classic ketogenic diet, you probably are bringing your food with you places most often.
Yes.
Is that right?
Yes. Yep.
Yeah, and modified Atkins or low glycemic index, you may be able to go to a restaurant and order something off the menu and maybe adapt it or shuffle things around a bit or order a la carte in a way to be able to get something that works with the diet. But yeah, I'm guessing that the traditional, it would be pretty hard to be able to do that at a restaurant or just a regular school lunch or any of those types of things.
Yeah. Yep. And just because those food items have to be weighed on a gram scale, it would be very difficult,
Right.
To bring those things to restaurants too.
Sure. So what are some common tips and tricks to help people stick to the diet and also some patient and family characteristics that are kind of predictive of success? And then also some of the most common pitfalls that might lead to discontinuation.
So I would just start probably by saying plan as much as possible. Plan ahead as much as possible that you can, that you're able to do. Stick to simple recipes, meals that the family knows that they can maintain for at least 3 months. Then expand to complex options. We don't want to make this too difficult especially in that first 3 months to where they're just ready to throw in the towel too soon because we tried to make it too complex for that time. Prepare on-the-go snacks ahead of time so there isn't temptation to grab something that isn't compliant. Try to incorporate the other family members' foods as much as possible into the diet therapy for the child so that things seem similar. So, for example, if the family's having chicken, broccoli, and mashed potatoes, maybe the child on the diet therapy could have chicken, broccoli with butter, and then maybe rice or mashed cauliflower instead. So they still feel somewhat included. Educate all caregivers involved in the child's life of how important the diet therapy is so that they can help advocate for the child and remind them why they're on it and support them through that journey. And then, another great important thing is work with your keto team, dietitian to find substitutes and or alternatives that are acceptable for the ketogenic diet therapy that may help your child stay on the diet longer if they can have those items or something similar to those items. I typically find that parents and families that are very motivated, that come to us with questions about the diet therapies, that take the extra time to get organized and plan ahead. So when I typically meet with the families, I try to encourage them to sit down, plan ahead, make a grocery list, all that stuff. Families that are able to do that or willing to commit to that are typically more successful in the long run. Some pitfalls, I would just say not taking enough time to plan or prep before starting the diet therapy, or not feeling like they are comfortable enough to educate those around them about why they're going to be on the diet therapy. So that makes them feel more isolated and sometimes embarrassed to explain that to other members of their family or other people that are involved in their lives. And I do see some of those kids kind of fall off the wagon a little bit more.
Okay, great. So now often patients and families will ask if simply shifting their regular diet toward one that has more fats and fewer carbs will be effective at reducing their seizures. Are the diets that we've discussed kind of all or nothing, or can simply incorporating elements of the diet have some benefit, specifically in terms of seizure control?
I do hear a lot this kind of question that when I bring up possibility of using ketogenic diet as a therapy, I do hear, well, maybe we could start doing something today. And as a general statement, I usually say that while it may be a great idea to reduce amount of processed sugars and amount of preservatives and artificial sweeteners or food coloring or fast food proportions to their daily meals, it is not expected that just simple reduction in sugar without other changes that happen and other adjustments that we make in dietary intake for patients on ketogenic diet will result in that dramatic and a fundamental shift in metabolism from consumption of glucose as a source of energy to shifting away from the glucose consumption to fat consumption. Without very specific changes that lead to that shift, ultimately depriving body of easy access to glucose, you will not see the same effect as we see from the ketogenic diet. That being said, high glucose content in everyday meals may contribute to, in some patients, to the level of neuronal irritability and inflammatory changes and seizure increase, and reduction in sugar content may improve seizure control in some patients. However, it's more of a hit or miss or anecdotal observations rather than a statement that I can extend to the broader community. And
Right.
that's kind of the expectation that we have.
Yeah. And certainly reducing sugar and refined carbohydrates and processed foods and all of that is healthy in any case.
Yes.
So it
Exactly.
certainly won't hurt, but it can probably not going to have a direct impact on seizure control. So
Yes, and as we usually say, healthy body leads to better epilepsy treatment and better seizure control. However, it is not my expectation that reduction in, let's say, in soda consumption will promise a better seizure control. If they feel better from day to day with those changes in their everyday meals and nutrition, I think it's great, but I wouldn't put an expectation on that approach as a means to control their seizures.
Okay. So we've got about 8 minutes left, so I want to open it up for questions. Okay, who's got a question they'd like to ask?
Well, this is Irene, and I was wondering, do you stop the seizure medications after the diet is in place to see if it can control it without medications, or how does that work? I mean, how do you know what after you're on the diet when you can reduce the medicines or try to go off of the medicines, the seizure medications?
Very good question, Irene. This is very individual. It depends on the reasons why epilepsy is there or why seizures still happen before the diet is started, what medications you take or how many medications you take. And after diet is started, your neurologist or neurologist who's managing epilepsy continues making assessment of effectiveness of the diet and seizure control, and if seizures stop after diet is initiated, then a reduction in medication is a definite possibility. In many patients, it happens. Usually not recommended to just stop medications when you're on a diet. We never would recommend doing that on your own routinely. Usually, if there are multiple medications in place, one that is considered least effective or that comes with most negative side effects that contribute into the tolerance of medications or overall how patients feel, to start reduction of that medicine under the guidance of the neurologist who's involved. And over time, depending on how seizures remain well controlled or only partially controlled, or additional changes occur while initial reduction is planned, then further changes are recommended based on that individual circumstances. But it is absolutely possible, and it is very reasonable to consider a reduction and discontinuation of medications in patients who have good seizure control on ketogenic diet.
Okay. Thank you.
Okay. Good.
You're welcome.
Maybe time for one more question. Does anyone else have a question?
Can I ask another one?
Yeah, if no one else has a question, absolutely.
Okay. Is the mitochondria diet, the mito diet, the same as ketogenic diet?
The short answer is no.
Okay.
And whenever, fortunately or not, for a variety of reasons, and for ketogenic diet having a dramatic effect on weight of a person who is using that diet, it became very, very popular out in the community and in the media, and it is advertised as one of the ways to control weight or ways to reduce weight. And under that umbrella, there are so many different things that are advertised that they may or may not have a lot in common or even be ketogenic when it comes to it. So I would suggest if somebody is targeting ketogenic diet, find a professional who is experienced and educated in management of ketogenic diet. Find a dietitian who is experienced or at least willing to learn and manage dietary regimen that we call ketogenic diet. And I would not recommend doing that on your own.
Okay. Okay, thank you.
You're welcome.
Okay. All right. Well, it is 7:30, so we should wrap it up. So thank you so much to both of our speakers for an excellent conversation, and I always learn a lot from these, and today is no exception. So, and thank you for everyone for joining us today. If people do have any additional questions or want to learn more about the ketogenic diet or other therapies, certainly visit our website at epilepsymichigan.org, or you can visit the national office's website at epilepsy.com. And you can always give us a call at 1-800-377-6226, and we'd be happy to answer any questions you might have. So thanks again to our speakers, and thanks everyone for joining us.
Thank you very much, Russ. Thank you for this opportunity.
Yes, thank you for having us.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye.